Good evening. I'm Deana at the University of Cincinnati, and I'm pleased to welcome you to this Hand in Hand webinar series of the American Association for Hand Surgery in collaboration with the American Shoulder and Elbow Surgeons and the Orthopaedic Trauma Association. We'll be discussing acute and chronic elbow instability, what's new for 2025. It's my pleasure to introduce our moderator, Dr. Deana Mercer from the University of New Mexico. Deana, why don't you take it away? Oh, I think you're muted, Deana.
Oh, thank you. Thank you. It is such an honor to be here, and Dr. Jane and I have put together a really superb faculty who are going to educate us on elbow problems. We have Jennifer Tangtiphaiboontana, who will be talking about acute posterior medial elbow instability and coronoid fractures. Dr. Biswas, who is going to talk about acute posterolateral elbow instability. Dr. Gray, who has outdressed us all, and he'll be speaking on medial elbow reconstruction. Dr. Cassidy, lateral elbow reconstruction, and Dr. Orbay is going to talk about post-traumatic elbow stiffness. We'll have a few minutes for question answer. I encourage you to please put questions in the chat. I will then keep up with that and present questions to the speakers as we go along. So we won't have anybody unmute, just put it in the chat, and then I'll make sure that we get to them. And if we don't get to them during the talk, we'll do it during the question answer portion of the webinar. And on that note, I think we can get started. And our first speaker is Dr. Tangtiphaiboontana.
Awesome. Thank you so much, Dr. Mercer, for the introduction, and honored to be a part of this webinar. So I was tasked with discussing acute posterior medial elbow instability and coronoid fractures. So what I'll hope to cover in the next 10 minutes or so is helping our audience kind of define the injury, really learning how to recognize it, review some of the current evidence that's out there, and then also how to surgically manage these injuries. So posterior medial rotatory instability is a pattern that's typically sustained when the patients fall backwards as opposed to forward on their arm. The arm is typically internally rotated, and what that results in is an axial loading across the elbow with a combination of a varus force while the arm is in pronation. And so what that then results in is typically a fracture of the anterior medial facet of the coronoid, a rupture of the lateral ligament, and occasionally an injury to the medial collateral ligament as well. Why is this important? I think it's a good reminder that the lateral ligament and the coronoid together work to resist varus stresses that are across the elbow. If you imagine what we kind of do in our day-to-day life, gravity puts a lot of varus force across the elbow, particularly when we're lifting things away from our body. And what happens when PMRI or posterior medial rotatory instabilities go missed, or they're missed or untreated? This is a biomechanical study done by Dr. O'Driscoll demonstrating that in PMRI elbows, there's a decreased contact area and increased contact pressures that potentially could lead to rapidly progressive arthritis if these injuries are missed. So here's a case example of a 68-year-old woman who slipped and fell on ice, as is typical at this time of year in Minnesota. This is some representative CT scans demonstrating a coronoid fracture after her closed reduction in the ER. And I think what's particularly challenging about coronoid fractures is deciding which ones are clinically relevant and how do you assess elbow stability. So when we talk about coronoid fractures, Dr. O'Driscoll's classification, I think, really highlights or calls attention to the anterior medial facet. And so he described three broad categories: tip fractures, anterior medial facet, or anterior medial fractures, and then basal coronoid fractures. And I think really the challenge for most of us is deciding, is it a tip or is it an anterior medial facet? And then, you can see the subtypes listed there. So what I'm going to do is hopefully go through some of the CT findings that are pretty indicative of a fracture of the anterior medial facet. And so I find that 3D reconstructions on CTs are actually very helpful. And if your radiologist can do this, subtracting the humerus, so you can get this view of just the ulna is incredibly helpful. So some features include a downward sloping fracture pattern, a concave shape And what that demonstrates is sort of the impaction of the trochlea as the elbow subluxates or dislocates. And then occasionally these fractures can extend in or below the sublime tubercle with involvement of the medial ligament. Now, if you're working in a facility that doesn't have 3D reconstruction capabilities, this is also a really nice view that you can do on your 2D reconstructions, again, demonstrating sort of that medial downward pattern, and then also the concavity of the coronoid fracture. And so the other thing sort of to tip you off or to raise your suspicion that this might be a PM&R pattern is the clinical presentation. So oftentimes the radial head is intact. Some patients typically don't actually have a frank dislocation. They might say they felt a clunk, or on an x-ray there might be subluxation of the ulnohumeral joint. And then on exam, some patients will complain of crepitus with elbow motion as they move their elbow with their arm abducting away. And so once you've successfully diagnosed this injury, the question then is, do all of these injuries require surgery? And the answer is no. So this is a nice study done by Dr. Athwell and Dr. King, small cohort study looking at 10 patients with anteromedial facet fractures that they treated non-operatively. I think it's critical to look at the inclusion criteria. So they ensured that there was a congruent joint on X-ray and CT scan, that the patient had a stable arc of motion, and then on clinical exam, that they had a normal hyperpronation stress exam as well as a stable gravity varus stress exam. And that's a photo demonstrating how they did that. And if patients met those criteria, they went down a non-operative path, and patients actually did quite well with union of their fracture, good outcomes. And the other thing they observed is most of these patients that met these criteria actually ended up having pretty small, minimally displaced subtype 2 anteromedial facet fractures. So one thing to kind of keep in mind. So how do you stress an exam under fluoroscopy? The image on the far left demonstrates what a positive varus stress would be like on coronal view. Cross-table lateral stress, this is sort of my preferred to look for instability. So you can see there that there is some posterior subluxation with pronation, ulnar gapping with pronation and dropping of the joint itself. And then this is an example of what happens when you put the arm in abduction with some internal rotation, again, reproducing sort of the varus stress that most elbows would see in sort of day-to-day life. So now that you've proven that it's unstable and you need to go down the operative path, the question is, what do you address? So there's the coronoid only, you can just fix the ligament only, or you fix both the coronoid and the lateral collateral ligament. I think it goes without saying that the lateral collateral ligament is pretty important. And so this is another biomechanical study done by Dr. O'Driscoll's lab demonstrating that in PMRI elbows where the LU cell is deficient, that the contact pressures on the cartilage, dramatically increases. So again, it plays an important role in varus stress. This is another study done by Dr. King, looking at the size of coronoid fractures in ligament intact and ligament deficient elbows. And so in this table, what they demonstrate is how altered are the kinematics and how unstable is the elbow. And you can see that in ligament deficient elbows, when the elbow is in varus, that it is quite unstable. Now, what happens if you repair it? So you can see that even after you repair it, there's still some abnormality in elbow kinematics, and that seems to vary based off of the type of anteromedial facet fracture and also size. So, not all the PMRI patterns are the same, as you have to consider the coronoid fracture itself as well. And so this is a clinical study that sort of tests this theory. So this is the treatment algorithm proposed by this group. So what they asked themselves was, well, let's look at the size of the anteromedial facet fracture, and is it big enough for us to fix? And if the answer was yes, they would fix the coronoid, and then they would re-stress the elbow. If the elbow was stable, that's all they did. If it was unstable, they would then go on and fix the lateral collateral ligament. If the fragment was too small, they ignored the ligament, did their stress exam. And again, if it was unstable, they fixed the ligament. And if it was stable, then they went down a non-operative path. And in their cohort, their patients actually did quite well, and there was no evidence of recurrent subluxation by following this algorithm. So if you do decide that the coronoid needs to be fixed, here are the various sort of medial approaches to the elbow. I won't spend too much time on it, but my preferred approach at this point is what's called the extended medial elbow approach. And so these are just some cadaver photos demonstrating where that interval is in relation to the FCU split approach, which I think is a pretty easily identifiable approach. But once you open up that interval, you dissect through the FDS, and here are some sort of important structures. You elevate the ulnar head of the pronator teres. You can see the brachialis there, and you do have to end up lifting off some part of the brachialis, but you can see that you've got a really nice access to the coronoid, and you don't have to worry too much about the ulnar nerve. So if you're talking about coronoid fixation, do you do a buttress plate or do you do screws? This is a biomechanical study comparing the two options. So screw-only fixation, non-lock plating, and locked plating. They tested in various types of load, tension load, compression load. They looked at fracture displacement and also load to failure, and they found that the fixation was best achieved with the plating technique over screws. This was a clinical study that compared plate fixation to screw fixation. Again, retrospective study of 28 patients, those small numbers. Interestingly enough, none of their cases they felt the need to do a lateral ligament repair, but they found that screw fixation the only difference was that there was shorter OR time, but that generally speaking, there was no difference in pain, complications, motion, or outcome scores between plates and screws. The limitation is, there's certainly a lot of surgeon bias in this study where the smaller fragments tended to be fixed with plates and larger fragments were fixed with screws. So again, something to note when interpreting the results of this study. So in summary, I think, recognizing PM&R is incredibly critical. In my practice, I think CT scans with 3D recons is a must to really kind of understand what type of coronoid fracture you're looking at. For certain select patients, non-operative management is certainly doable, but I think it's our job to make sure that the elbow is actually stable. And then if I am treating these operatively, my preference is to use the extended medial elbow approach. Again, also for coronoid fixation, plating, seems to maybe outperform biomechanically dense screws. I tend to be a plater. I think with these shear fractures, they need a buttress plate. So my bias is towards that. And then the LUCL, I think, based on your stress exam after you've addressed the coronoid. Thank you.
Awesome. Thank you. That was fantastic. So next up is Dr. Biswas. And then you just need to unmute.
Sure. Can everyone hear me okay?
Yep, perfectly.
Okay.
Awesome.
All right. Thanks for having me, guys. My name is Biswas. I'm in the west suburbs of Chicago. I agree that was a fantastic talk by Jennifer, and I was tasked with discussing posterolateral rotatory instability, and I think that topic probably mandates a discussion of terrible triad injuries as well. These are my disclosures right here. Summary of what we're going to talk about tonight is starting off with a discussion of the anatomy and the injury mechanism of this condition, and briefly talk about non-operative management with some recent advances, and then really kind of talking about when we have to operate on these patients and talking about some of the more recent innovations that have been developed. So stability of the elbow joint, as we know, is conferred by the bony constraints of the elbow, including the ulnohumeral articulation and specifically the coronoid and the radial head, which serve as a buttress against posterior instability. And we also know that the soft tissue structures are equally important, such as the lateral and medial ligamentous complex, and also contraction of the biceps and the triceps, which serves to concentrically contract the greater sigmoid notch against the trochlea to help maintain reduction. And so in injuries involving posterolateral rotatory instability, the typical mechanism, as you know, is typically a fall onto an outstretched hand that generates an axial load, a valgus force, and then external rotation torque of the forearm against the humerus. And that leads to a somewhat predictable injury spectrum. beginning typically with a disruption of the LCL, followed by soft tissue and capsular injury in stage 2, and then finally leading to medial-sided failure and frank elbow dislocation. And this can lead to fracture dislocations, particularly when there is an anterior shear injury of the coronoid and the radial head that can lead to severe instability of the elbow. And so, as we all know, vast majority of simple elbow dislocations are managed non-operatively with early rehab. And it's important to understand a key concept that's emerged recently, and that's been the promotion of supine-based motion protocol. So in this diagram, in an upright position, we can see that gravity, the effect of gravity, is serving to distract the joint, right? It's detrimental at maintaining reduction as the biceps and triceps are attempting to contract the forearm into the trochlea. Whereas in a supine position with the elbow essentially upside down, gravity is now serving to help augment or to facilitate reduction by reducing the elbow-humeral joints, resulting in a complementary reactive joint force when motion is performed specifically in an overhead supine position. And that really is the basis of the protocol described by Dr. Hotchkiss, where for simple elbow dislocations, early motion, including extension on an unrestricted basis, is performed in a supine position with the shoulder forward flexed and internally rotated. And that really serves to eliminate a varus and valgus moment on the elbow to really promote ligamentous healing, and then also allowing motion in this position and minimizing stiffness. Another concept that's important to understand is that the biceps and brachialis can undergo a temporary neuromuscular dysfunction in the setting of any elbow trauma, certainly after a dislocation. And it's similar to the pseudoparalysis that we would see in the shoulder, for instance, after a glenohumeral dislocation. And it's common after an elbow dislocation for there to be, quote unquote, a drop sign. This is described by Dr. Duckworth, who noticed this and noticed the similarities between this and shoulder instability. And the way that they treated this was to actively promote biceps and brachialis contraction to encourage a flexion-based OT protocol. And you can see in this series how that eventually led to a concentric correction of that sag in the ulnohumeral and radiocapitellar joints. And this is something that we use routinely for non-op management, but also during post-op rehabilitation for elbow fracture, dislocation, surgical cases. And so, again, when I do this in my practice, I use that overhead protocol for the first couple weeks, and then recheck a set of x-rays. And if the elbow is concentric at that point, then I have confidence in transitioning them to an upright motion protocol and then having them progress through their therapy. But we're here tonight to kind of talk about some operative indications for posterolateral rotatory instability. And in my practice, the indications are to either when you're unable to maintain concentric reduction of a quote unquote simple elbow dislocation that has no obvious fractures, and then obviously with elbow fracture dislocations and terrible triad variants. So for fixing a complex simple elbow dislocation, to me, this is when you have a patient who has no obvious fractures but cannot maintain reduction or concentric reduction inside of a splint. And in my experience, this likely and most commonly occurs in patients who are morbidly obese, where their pannus or their body habitus is consistently placing a varus moment on the elbow that is just leading to persistent lateral instability and subsequently inability to maintain reduction in a splint. And the treatment for the majority of patients is an isolated LCL repair. And it's important to understand where exactly the LCL is. There are a variety of lateral approaches described to the elbow. And this is a study done in Italy that evaluated specifically the Coker interval between the ECU and the anconeus. And they essentially found that deepening that interval places the surgeon directly onto the lateral ulnar collateral ligamentous complex. And for that reason, in my practice, it really is sort of the workhorse approach for the majority of cases of posterolateral rotatory instability, either during primary repair or during a terrible triad. And that leads to a segue into terrible triad injuries. And we know that these are the principles on how we treat those. We address treatment of all the bony injuries, either radial head fixation or arthroplasty, fixation of any significant coronoid fractures. And, you know, a question always is going to be whether or not we approach those through the lateral window or if we do a medial sided approach. And then finally, repairing all the soft tissues that were disrupted, most notably the LCL. And then recently, introducing joint stabilization in cases that are challenging, where reduction cannot be maintained. And I'll show a few cases of mine that'll illustrate some of these concepts. And so this is a 69-year-old female who actually did have a documented elbow dislocation, and she experienced this widely displaced radial head fracture with significant metaphyseal comminution. She was reduced, and you should note on the radiograph how there is evidence of a UCL avulsion from the medial epicondyle. And so in the setting of instability, the options, as we know, are to either fix the radial head or to replace it in the setting of an unreconstructable radial head fracture. And I would say, and I think most surgeons would probably tell you, that a stable radial column is imperative, especially in cases of dislocation, because a stable radial column is necessary, again, to resist that valgus stress that's on the elbow in this particular setting. And I would tell you that fixation or ORIF should really only be reserved for cases where you are confident that you can confidently execute reliable and durable fixation. I believe it's far better for a patient's outcome to have a well-done, stable radial head replacement in the setting of instability compared to a tenuous ORIF, even in younger patients. So that's what we did for this patient. She had a head replacement with an LCL repair that we did through bone tunnels, and she ultimately had a pretty favorable clinical outcome. Now, this is another patient. She's 41 years old, morbidly obese, with a BMI of 54, with this terrible triad injury that could not be maintained in a splint. So I took her to the OR, I did her head replacement, I repaired her LCL, and she was still unstable. And so I went immediately and repaired her MCL, and she was still unstable. And so then we were in a little bit of a pickle here about what to do. This is an algorithm that was recently published in a Yellow Journal article with the Journal of AAOS. And ultimately what they say, or what they promote here at the end of these cases, is what to do when the elbow is still unstable. And the question is, what kind of joint stabilization will you ultimately decide to pick? And so it could either be an external fixator or an internal joint stabilizer. And recent studies have recently demonstrated and compared the advantages and disadvantages of both techniques. This is a series by Tim Fowler out of Iowa that showed a statistically higher incidence of complications with X-Fix, including infection. And this is a systematic review that showed higher rates of residual instability in X-Fix as compared to an internal joint stabilizer. And so in my practice, which has been consistent with emerging trends, has really advocated for the use of an IJS in challenging cases of elbow instability, where isolated treatment of the bony injury and soft tissue repair could not confer adequate stability. So in this patient, we applied an IJS intraoperatively after she was unstable after all of the soft tissue repairs. And she ultimately had a favorable outcome right here. This is another case of a terrible triad in a 67-year-old female. She was reduced, but you can see some of this persistent ulnohumeral gapping. And you can also see that she has this sort of type 1 coronoid tip fracture on the CT scan right there. So a variety of techniques have been described that we're familiar with for a fixation of coronoid fractures, including posterior to anterior fixation, especially once a radial head is being, especially once a radial head replacement is being planned, which can be accessed through a lateral window, and also suture lasso techniques for these tip injuries. But this was a study done by Daphne Beingaster and Graham King that really demonstrated that treatment of those type 1 tip fractures is probably not necessary, as it has really minimal effect on the outcome. So I replaced the radial head on this patient. I tried to repair her LCL with a cortical button, and she was still unstable here despite the treatment of the bony and soft tissue injury. And so again, I placed an IJS, and she was stable in the operating room. She later developed a little bit of heterotopic ossification in the anterior capsule, but we removed the IJS several months later, and she ultimately had a very favorable clinical outcome. Now, this is my final case. I know I'm running over a little bit. This is a 78-year-old female who had a posterolateral elbow dislocation with a pretty comminuted coronoid base fracture. She was unable to stay reduced inside of a splint. And this was her CT scan right here that shows a comminuted fracture of the radial head of probably about the anterior 50%, and what appears to be a pretty sizable type 3 coronoid base fracture. But on the CT scan in the 78-year-old, you can see that this bone quality doesn't look that great. So we started with a lateral approach. I excised the radial head in preparation for arthroplasty, and I evaluated the coronoid through a lateral window and found that that bone was incredibly soft. It was poor quality, and it was insufficient, in my opinion, to support fixation for P to A screws, or even A to P screws. So at that point, I placed the axis pin for an internal joint stabilizer, as well as the base plates, to facilitate linking those components at the end of the case. And if the coronoid can't be fixed from a lateral approach, then I believe that coming in medially can be helpful. I know Jennifer spoke really briefly about medial exposures, and this is one that I've liked to use recently, where the flexor pronator mass is essentially advanced distally by making a proximal base flap of the flexor pronator tendinous origin. The ulnar nerve is decompressed, and the flexor pronator mass is then elevated along with the brachialis, allowing for exposure of the trochlea and the coronoid and placement of a fixation. So I went medially on this case. I performed that approach that we talked about. And I think a key part of any coronoid ORAF is to make sure that the ulnohumeral joint is firmly reduced. And a nice trick to do that is to take a large point of reduction forceps and to place one time on the articular margin of the trochlea and the other time on the sub-Q border of the ulna, and then to clamp that together so that the ulnohumeral joint is firmly reduced. And then the trochlea can essentially be used as a template for coronoid reduction, which I pinned here and then placed this coronoid buttress plate. I completed the radial head arthroplasty and then linked the components of the IJS. And this patient was stable, and she started early range of motion postoperatively. And so briefly, just to summarize, you get one shot at elbow instability. I've been practicing for about 10 years now. These are some of the most challenging cases in my practice. Your best shot is usually your first shot, and you want to avoid post-op recurrent instability. I think this is one of the hardest problems that we treat in our field, and we have a lot of tricks now, and I recommend that you leave the OR with confidence. So that's all I got right there.
Thank you, Dr. Biswas. That was fantastic. Our next speaker is Dr. Gray, who will be speaking on medial elbow reconstruction. Take it away.
Thank you so much. Hard to follow those first two presenters. It's fantastic. So we're going to talk about what happens, I guess, on the medial side when you don't get it right the first time. I completely agree. You should try to get it right the first time, but it doesn't always happen. All right. Here are my disclosures. We'll go through this pretty quickly. It's important when you're thinking about the medial side, there's two types of instability. There's ligamentous insufficiency, which gives you valgus instability of the elbow. There's osseous insufficiency, which gives you varus instability of the elbow. So the direction the elbow is pointing, you can have the elbow point the wrong way with a medial-sided injury, depending on what is hurt. Right? So let's focus on ligamentous injuries first. I'm going to warn everyone, this is going to make me even less popular in general, and certainly among my sports partners who I love so much. So we got to talk about Tommy John a little bit. It's definitely built sports medicine as a discipline. It destroys ulnar nerves and sometimes median nerves as well when you can't find the palmaris. But this surgery is sort of an imbalance between our anatomic understanding and our understanding of pathophysiology. We definitely know where that ligament is for sure, but this is typically, this is often an acute injury, like a skier's thumb kind of analog. The one that really needs to get reconstructed is the chronic injury, the gamekeeper's thumb analog, the attritional rupture. And that's, you're definitely going to see that with overhead athletes, especially baseball players the most. Now, who gets this? Every single elbow dislocation has a UCL injury. They also have an LCL injury. They have a capsular tear. They have all this stuff. The reason you're not fixing these on simple dislocations and you are for these PMR situations is because when the elbow acutely ruptures everything, first of all, its healing potential is better, but also it's symmetrically out. When you have this spinny, twisty ligament tear sort of thing on either side, the intact side remains intact and everything spins around that, and the elbow does not like that. So some overhead athletes definitely get this, not all of them. And it's also, do not forget the grappling or wrestling athletes. Now, who do we fix? The overhead throwing athletes or grappling athletes who fail therapy and have got clinical instability. But basically nobody else. I think this is an overdone operation. One of the tests, they talk about this for looking at PLRI and looking at the LCL. I think this is at least as good for looking at the UCL. If the athlete can push himself off the chair and like keep their feet off the ground, they don't need to get fixed. Like this person can rehab this injury almost all the time. Very high level pitchers, you can maybe make a case, but usually if they can pass this, they don't need surgery. Now, why do quarterbacks not get this, or definitely don't get fixed the way baseball players do? Well, first of all, they release the ball a lot higher than pitchers do. Their elbow tends to be out and forward. And when they do get this injury, it's usually because they're throwing and someone's running into them and the elbow cracks and like a whip and you tear the ligament acutely. That acute rupture, those scar down pretty well. It's the attritional rupture that doesn't. Same thing with tennis players, right? These guys are putting enormous velocity. They're hitting gas with these arms. They don't get this injury. Why? Basically because they don't let go of the racket. And when you keep your hand on the racket or the ball or whatever, it keeps the kinetic chain closed and it forces you to fire your scapular stabilizers as a brake. So you're not just pulling through your elbow, you're pulling back through your shoulder. And this insight is the key to rehabbing these injuries. So I have all these patients learn about towel drills. And they're like, what's a towel drill? I'm like, if you haven't done towel drills, we're not ready to talk about surgery yet. You do them on your knees, you hold the towel in your hand, you practice your throwing motion, and you don't let go. It keeps your elbow out in front, and it really forces you to activate the obliques, because the real key to throwing gas and protecting your elbow is a strong core. Now, a lot of times I'll get these usually it's juvenile patients and the parents are in there, and Johnny is going to be an all-star. He throws gas, like, we gotta fix him. And I'm like, look, with all due respect, Johnny, lift up your shirt. I'm 45 years old. If my abs are better than yours, like, we have a different problem. And this is why your elbow is breaking down. And this is why your elbow will break down again if we reconstruct it. So we got to solve the root cause first. Now, sometimes you do have to fix it. And so when you fix it, people are scared of the anatomy over here. The key thing to understand is the ulnar nerve is the key to the medial side of the elbow. The nerve is completely in front of the UCL. So in order to get to this UCL, you got to move the nerve out of the way, at least temporarily. And that's where the UCL wants to live. You got to release the nerve way up and down, not just like a little tiny window right where you're working, because otherwise you're really going to torque that nerve. People do get ulnar neuropathy after this surgery. You can do a Taylor sham approach where you can pull everything off of the olecranon. I prefer more of an FCU split. I want to leave as many of the muscles as I can attached to act as dynamic stabilizers to the elbow after this. You got to add collagen at some point. I actually think that allograft is just as good as autograft for these. And then this is one thing where your heavy stitch construct, the bat shoelace kind of stitch thing, I do think really helps splint the repair so that it can heal appropriately. Now let's talk about the bones. Medial osseous instability leads to varus instability. And as we were discussing earlier, every human activity has the shoulder and abduction, which puts this torque lever arm on the elbow, which will push you into varus if you don't have a coronoid. The LCL can survive this for a while, but if you don't have a coronoid, it will eventually fail, attritional rupture, PMRI. So let's talk about subacute coronoid loss. Deb showed a case sort of like this. This is a younger guy, but an older injury, terrible triad. You go lateral, you look at the radial head, it's trash. We're going to have to replace that. And then you go medial and you look for your pieces of coronoid to fix and you get this, right? And so this is not, no plate, no screws are going to hold this in place. So you got to look for another option. So this is just like Deb showed, you can use your radial head as acute bone graft. And here, use screws. You can use a plate if you want to. It doesn't really matter. Finish your reconstruction. I think it's vital, especially for the osseous reconstructions, that you back them up with something to make sure the reconstruction takes. So whether that's an internal fix, an external fix, whatever it is, but you got to keep this elbow stable until that bone heals. Now let's talk about a more chronic coronoid deficiency. So you'll often see these in cases where the terrible triad was not recognized or just not treated appropriately. And here's a sad, terrible triad, right? They replaced the radial head and kind of nothing else happened and there's no coronoid, right? And so when you open up medially, you see the area where a coronoid used to be or should be. And I need bone. I can't use the radial head anymore. It already got replaced. That's in the trash. So iliac crest here is a great option. You can get this nice big piece of tricortical graft. You can fix it into place, hold it with a screw from the base plate of your stabilizer, a headless screw or plate or whatever you want to do. And then once it's in place, you can use a little burr to taper to make sure it just fits in that notch on the humerus just perfectly. Now, sometimes you're missing too much bone and the crest isn't enough, right? So these are not everyday injuries, thank goodness. And you all the king's horses, all the king's men, put everything back together, and still sometimes it just doesn't quite work out, right? And so you gotta fix this. You gotta figure out a solution for this problem. And so fibular head autograft bone fits very well. They don't miss it. You can take this out. The knee still stays very stable with this. And you can take this, you use a saw to kind of give yourself some cancellous bone. And so you can fix that cancellous bone back to the rest of your ulna. Nice long construct for this to heal. It gives you a lot of bone that you didn't have before and gives you a nice buttress to that PMRI dislocation. So takeaway points: medial ligament insufficiency leads to valgus, rarely needs surgery in my opinion, rarely needs surgery. Medial osseous insufficiency leads to varus, always needs surgery. And back up your reconstruction until it heals. So if you're doing a soft tissue thing, make sure you put some big, super heavy stitches in there. If you're doing a bony thing, do something with metal to back that up. Thanks so much.
Awesome, Dr. Gray. Fantastic cases. So next up is Dr. Cassidy, who will be talking about lateral elbow reconstruction.
Good evening. Thanks to all for joining us tonight. And I've learned a lot already. Nothing to disclose. I like that twisty thing that Dr. Gray said. So when we think about posterolateral instability, it's not the radial head that's dislocating. It is the forearm that's hypersupinating. So if you look at it from behind, the orange would be the radial head. And you could see the radial ulnar connection is not disrupted. It's the loss of the sling, and that needs to be restored. That's that twisty thing. So when we're thinking about reconstruction, let's talk about confounders, talk about repair with augmentation, reconstruction, and special circumstances. First, the confounders. Is the bone okay? So on the left, we see a capitellar defect that can result in instability of the elbow. Now, that can be treated by building in a contracture so that the elbow doesn't extend enough to articulate with that, or resurfacing that defect. And on the right, more commonly, we see loss of part of the radial head, which is a buttress. And if that's not repaired or replaced, it will predispose to instability if you try to just do a ligament reconstruction. The third is cubitus varus, and we'll talk a little bit more about that, tardy posterolateral instability from childhood supracondylar fracture. Next, we'll talk about repair with augmentation. Here's a case example, a 43-year-old male, labor. He felt a pop while lifting something. He was diagnosed with lateral epicondylitis. He had a couple of steroid injections. He had a sense of instability. You see on his MR on the left, the coronal view, you can see a little stump of the ligament. So the ligament's torn. And on the sagittal view, the radial head is translated posteriorly relative to the capitellum. And this view is quite helpful, I think. Seeing fluid tracking under the soft tissues at the lateral epicondyle is worrisome for ligament disruption, in contrast to just a tennis elbow situation. And then the ulnar humeral joint you can see is not congruent. So this is that patient. You can see posterior drawer demonstrates significant posterior translation, and he has a little bit more of a glide than a pivot, but his elbow is unstable. So here's a lateral exposure. It's the Coker, as we discussed. He has a plica, and I always will remove that plica. You can see interposed. But you have to peek under the flap. It may look like the soft tissue is connected to the lateral epicondyle, but it often is not. And in this case, it wasn't. And the tissue is sliding around, and so it's not restraining the joint. As we discussed earlier, there's a true isometric point for the ulnar humeral joint, best seen on the lateral, as you see there. It's important to identify this when you're doing a repair or reconstruction. And here we used suture tape augmentation, and the guide wire for one of the anchors in the ulna is used as a post. And then we'll extend the elbow, flex and extend it, and it's always a little bit more proximal than you think to find that isometric point. So we want to maintain reduction of the elbow, keep it pronated as we flex and extend, and make sure that the tension is the same on that suture throughout the arc of motion. So that's that spot. And once we have that spot, the drill hole is going to be a little bit more proximal and posterior, so that leading edge, you can see the little uncovered yellow part. That's really the isometric point there. So drill hole plate slightly proximal and posterior. If it's too distal, it's too loose in extension. If it's too loose in extension, it will be unstable. Capsular imbrication is really important. So if you look at this video, just me pulling up on that, you can see is reducing the radiocapitellar joint. So I put a series of stitches, they're pants over vest sutures, and then we'll tie some of them, but not all of them, so we don't interfere with the attachment point of the repair to the humerus. So number 2, running locking suture, and it's important to remember that the first and last pass determine the tension. We want to make sure the elbow is reduced, so pronate it, eliminate the varus. It's always easier to see if you throw in a little bit of varus, but it may be too loose if you tie it there. You want to have it in a neutral position and pronated before securing it. And those are the running locking sutures. And then that's the construct. We always want to put a stitch or two in, if you're using a tape augmentation, to connect that to the capsule, because the tape can actually snap back and forth, and this will eliminate that. Next, on to reconstruction. So same approach, Coker approach, and this is a matter of judgment as to whether the tissue is adequate for repair or reconstruction. Some of it has to do with chronicity, associated injuries, but to me, it's the sling on the backside. You can see the anterior side doesn't look bad, but the sling on the backside is incomplete, so it would never make it back up to the lateral epicondyle. So here we'll use a bone tunnel in the ulna. I pass a suture through it. Again, we're going to find the isometric point, as you see there. So I use the suture itself to determine the isometric point, and the suture, if you cut one of the limbs going into the hole, you can use that as a shuttle to pass your sutures for the tendon graft. So don't just get rid of that suture. That suture is valuable. And then isometry, as we talked about. So if that's the isometric point, the drill hole is going to be a little more proximal and posterior. And then I use a docking technique for ligament reconstruction. So I'll make a tunnel. It doesn't exit posteriorly, but it provides a little space so you have a little leeway in terms of tensioning. And then 2 Keith needles that are divergent from anterior to posterior through that tunnel, exiting at the posterior aspect of the lateral column. If the bone is good, you could tie it right over the column. If not, you can use a button over it to avoid cutout. So those sutures are placed. Again, you can see the imbrication sutures on the right-hand side. I use a docking technique, as I mentioned. All those imbrication sutures are pre-placed. They're the 2 limbs. The center image shows I've docked 1 limb, and then this is just like you do in an MCL reconstruction to determine the right length. Put a running locking suture in the second limb, remove the excess, and then pass that through with the other Keith needle, and there it is on the right-hand side. We've tied the imbrication sutures except for the most proximal 2 because they would get in the way of passage of the graft. And that's what it looks like. Again, you want to secure the graft to keep it from snapping. You can also tighten that V configuration, which will give you a little bit tighter reconstruction as you head toward the ulna. So for me, rehab day 1 to 10 in a splint, full pronation. Day 11 or so to 6 weeks, elbow brace, -30 to 130. But when they're out of the brace, I allow them to work on full extension with their forearm pronated, and they can work on forearm pronation and supination with their elbow at 90 degrees. I caution them not to do any weight bearing for at least 3 months and try to avoid varus. So their arm is a hinge. They can get up to the top of their head, but they should avoid putting their elbow out sideways. So a couple special circumstances, kind of a crazy case, but this is a 30-year-old woman, 6 weeks after injury to her elbow. She had pain, her range of motion was this. This was her lateral x-ray, and she was referred to therapy by her primary care physician. And this, you always got to get 2 views, obviously, and that's crazy, but it jumped a track. It's very deceptive on the lateral, but you can see it's off. This is intra-op. So the hand is to the floor. This is the medial side. No soft tissue attachments there medially. Lateral side, you see no soft tissue attachments either once we've done the releases. And my thumb is just holding the joint reduced, otherwise it would fall out. This medial ligament reconstruction, and on the lateral side, you've heard this already, but this is indispensable for these types of injuries to maintain stability and allow early range of motion. So this would be combined with a ligament reconstruction. And the axis is the key. So this is what I call the battle for isometry. So we talked earlier about the ligament wanting to be attached to the isometric point, but also the axis pin for the internal fixator needs to be in that isometric point, and the axis pin wins. That has to be in the perfect position. Otherwise, the elbow, you'll have a cam effect and the elbow won't be stable. The ligaments will stretch out. So here is my solution to that. Bone tunnel. We have 1 limb of the graft that goes through the bone tunnel. I take a Keith needle just under the axis pin, so I'm not making a hole any bigger, so we're not going to compromise that pin site. It's exiting posteriorly. The second limb goes through a little tunnel above the pin, so it's not going to compromise that pin either. And I have a little tunnel like a docking technique, and then it exits. So it gives you a little bit of leeway so you can pull the graft into the hole, make it tight, and then you're essentially surrounding the pin and not compromising the stability. So here's that patient a year after surgery. This is her range of motion. She had no interest in having the IJS removed. And then finally, cubitus varus and posterolateral instability. Sean O'Driscoll taught us about this tardy onset of posterolateral instability. This is a gentleman who had a childhood fracture. You can see his varus on the left. His elbow had been unstable following a minor injury several years earlier, and he had undergone a lateral ligament reconstruction with allograft, and he noted that his elbow was unstable in a cast. They put him in a cast. It was unstable in the cast. Here you can see the varus, and on the lateral x-ray, you can see the gapping of the radiocapitellar joint. This is a great CT. So he was able to feel his elbow sliding in and out. So I got a CT with his elbow reduced and a CT with his elbow dislocated. You can see it sliding off or twisting like you heard earlier. So very unstable situation. This is his MR. You can see the radiocapitellar joint is dislocated on the sagittal view when it was taken, and the tunnel for the graft is not in the right place, which contributed, but wasn't the only reason for the failure. So a lot of varus. I decided to stage it because of that hole that was in the not ideal place. So first we did a valgus osteotomy, and then I was hoping his elbow would be a little bit more stable, but this is how he was after that recovery. You can see his elbow is grossly unstable. And again, relying on just a soft tissue repair for this is probably not a good idea. This is an intra-op photo. It was actually from the first stage, but you can see that graft in the wrong place, nothing attached. So we took a couple of the screws out in the distal of the posterolateral plate and did the same thing as I had mentioned for the last case. And this is how he looks. And he has about a 5-degree contracture, full motion, and he's about 5 years out, and he does not have any interest in having his plate taken out either. So in conclusion, PLRI reconstruction prerequisites. You need to have an intact radiocapitellar articulation and a reasonable carrying angle. The spectrum of treatment it involves repair to reconstruction to augmentation with a suture tape or an IJS, dependent on the quality of the ligament and degree of instability. Quality is kind of a little bit of a judgment, as I mentioned, degree of instability. But remember, the joint will never be more stable than when you leave the OR. Thank you.
Fantastic. Thank you, Dr. Cassidy. And our final talk is a really simple, straightforward topic, post-traumatic stiffness, that will be presented by Dr. Orbay.
Can you hear me, Deana?
Yes, I can. Do you want to share your, yep, I see your screen sharing right now. Perfect.
Right. Thank you.
Awesome. Excellent.
Thank you very much, Deana, for inviting me to this webinar, and thanks all the other faculty for those fantastic talks that I much enjoyed and learned from. So my mission is to talk about stiffness, and this is my disclosure. So stiff elbows occur after around 12% of elbow trauma, and we define that by less than 100 degrees of arc of motion and of forearm rotation. The risk factors are prolonged immobilization and multiple surgeries. Stiff elbow can occur for, this is something that Dr. Mori described. They can occur from intra-articular, extra-articular, and mixed reasons. The extra-articular reasons, mainly, or very much on top of the list, is capsular fibrosis. The anterior capsule is notorious for developing contracture, and it's an extremely strong structure that can only be released by actually sharp surgical means. This is due to the proliferation of fibroblasts due to several chemotactic factors released. But let's not forget that there's also a posterior capsule. It's smaller, but it also can be part of the patients that lose flexion. The other type of extra-articular contractions, those due to the development of heterotopic ossification. And the intra-articular stiffness is usually due to defects of the bone or the cartilage. We indicate surgical treatment of stiffness after they have failed rehabilitation. In our experience, that means at least 4 to 6 months. And our rehabilitation includes not only active and active assisted exercises, but progressive splinting. And the recovery of forearm pronation many times is facilitated by serial casting into the position that is missing. Arthroscopic release versus open release has been studied multiple times, and according to systematic reviews, both techniques have about 90% success. That means getting a MEP score that is excellent or good. Open release tends to have more complications, but the literature, the indications for open versus arthroscopic release are always different. And nobody does open releases when they can solve it in a less invasive manner. In order to do surgery on these patients, you have to have a motivated, healthy adult that is willing to undergo the suffering that's necessary to get better. And again, the timing should be after 4 to 6 months, or when the bone, the heterotopic ossification is well defined. I don't know what mature heterotopic ossification really means. In my experience, it is when I know how far, how extensive the bone is going to be and what the limitation is going to be like. Pain is important. Pain at the ends of motion often are due to impinging osteophytes in the osteoarthritic or post-traumatic. Pain in the mid-range is due to articular cartilage damage, and pain with flexion after 90 degrees only is usually due to entrapment of the ulnar due to scar tissue. And this is a very typical and recognizable condition. Patient is recovering from an injury, and they get this neuropathic pain down the ulnar distribution when they flex. And the solution for this is a release of the ulnar nerve. Sometimes this is a little confusing because the neuropathic component might not be as clear. It's just pain upon increasing flexion. We consider the definition of loss of motion that requires treatment is an arc that is less than 30 degrees from reaching full extension or less than 120 degrees of flexion. Pronation and supination with less than 50 degrees in either direction is considered that is worth meritorious to treat. Sometimes patients with special vocational needs need releases of lesser degrees of loss of motion. Finally, the ulnar nerve must be explored, and we must understand if there's any pathology we should plan to handle it. We must discuss with our patients that the results are unpredictable, the rehabilitation is prolonged, and the complications are common. So the patient must buy into the plan. Arthroscopic release is less invasive and it's very useful. One nice thing about arthroscopic release is that your exposure, your access to the interior of the joint is much better than open, and you can certainly handle many things. Things that you cannot handle extra-articular problems like heterotopic ossification or ulnar neuropathy. The surgeon's experience in arthroscopy is also very significant and important. This is a patient that has isolated articular pathology, has serious limitation of flexion extension, and was treated by simple arthroscopic release and excision of the osteophytes. And the result was a happy patient. Open release is useful because it allows us to treat extra-articular problems like ulnar neuropathy, heterotopic ossification, and here we have a gentleman that has a long-standing elbow injury. He's now 18 years post-op, and his arc of motion is only 30 degrees, and he is very dysfunctional. He has had a radial head excision, and this looks like a very poor elbow, but we can do something to improve him. Just a simple release with excision of heterotopic bone and a capsular excision of the anterior and posterior capsule can give us a very happy patient, even though his elbow is not normal and not as strong as it used to be, but the increase in motion really makes a difference in the patient's life. In open releases, it's important to expose the neurovascular structures, the ulnar nerve. Many times the median nerve has to be exposed in order to protect it during complex releases on the medial aspect. And the radial nerve as sometimes there's great benefit of exposing it when doing a release of the lateral aspect. Open release will allow us to remove hardware and to remove, sometimes hard removal does not have to be complete. It can, in this particular case, after a distal humerus fracture that developed a vascular necrosis, collapse, severe stiffness, we proceeded to basically cut the distal part of the plates and then release and mobilize the joint and protect it with internal joint stabilizer of the old variety. Excisional heterotopic ossification is very important to achieve full range of motion, and that can include emptying out of the bone that forms in the coronoid olecranon radial fossa. Management of the radial head is also possible through open surgery during elbow releases. So the main problem, this patient was loss of motion, but the radial head was very deformed. There was a loss of forearm rotation also, and this patient was treated by an open release, excision of heterotopic bone, and a radial head replacement that returned significant function to this gentleman. Here, isolated releases or releases for particular forearm rotation problems can be done too. This is a young patient with prior radial head injury that healed with great deformity of the radial head and has great loss of forearm rotation. He has some loss of extension, not of flexion, but his main problem is forearm rotation. So we proceeded with a lateral approach, excision of the radial head. Nobody's too young to have a radial head replacement, but everybody's too young to have a bad elbow. That's something that Dr. Nathan Huxima has shown us. This is this young man that recovered full forearm rotation and improved the motion somewhat. Also, open release can be accompanied by interposition arthroplasty. That is a procedure that has benefits. Stabilization after an open release can be considered to prevent dislocation, to facilitate rehabilitation, and to maintain just joint distraction to safeguard your interposition during the healing process. So the internal joint stabilizer is something that our group developed several years ago, and we did publish a multi-center study on its effectiveness. It's important to prevent elbow dislocation after release. This is a patient with a very severe osteoarthritic elbow, basically no motion. And this seemed in my hands a little bit too much for arthroscopic release. So we did an open release. During the open release, the elbow resulted very unstable. And just to allow early rehabilitation, we applied an internal joint stabilizer that we removed later on, and we achieved a very good result. If you notice, the contralateral hand also had limitation that is pending treatment. Stabilization is important. This is a patient with combined stiffness, not only flexion extension, forearm rotation, and also an ulnar palsy, but also this patient has a SX Lopresti component, an axial instability component to this problem. He has some degeneration of the articular surface, but that doesn't keep us from trying to recover motion. In these complex cases, I prefer to do a medial and a lateral approach rather than a posterior approach because it gives me better access to the anterior capsule, which I think is better than just being released from the humerus. It is much better to excise the anterior capsule. You believe it will result in less chance of recurring the extension deficit. If we're going to use the internal joint stabilizer, the first thing we do after the read is to find the ulnar humeral axis. Notice this patient also had some loss of a coronoid. So not only did he not have a radial head, he had some coronoid deficiency, and he had all this instability and the stiffness problem that we mentioned. So the first step was to restore the axial alignment, and we utilized a suture construct for that purpose. So lifting the radial head to the radius to its proper level gives us the right height to be able to do our radial head replacement. So the key thing here is not to overstuff the radiocapitellar joint, because that would not allow the patient to recover full range of motion. And this is the motion that we achieved intraoperatively, and that's the forearm rotation that he was able to recover intraoperatively. This is the operated hand, and this is a mirror image of the contralateral hand, demonstrating that it is possible to restore the anatomical alignment in these cases. And at 20 weeks, this patient had an excellent result that is not due to the surgeon's ability, but to the use of the patient. Finally, interposition arthroplasty is facilitated by the internal gain stabilizer, and especially the use of the double telescopic internal gain stabilizer. That's the only version that is capable of maintaining this traction. Summing up, less is more. If you can do minimally invasive, you can do arthroscopy, it's better. Do open release for whenever you have extra-articular problems or very complex elbow situations. Stabilize to avoid dislocation, to facilitate rehabilitation, and to protect your interposition arthroplasty. Thank you very much for your attention.
That was fantastic. And that was a really nice way to present all the different types of stiffness, which, like Dr. Cassidy said, I'm learning so much tonight. So we have a couple questions. The first one is regarding the IJS. So we've had a couple of the presenters talk about IJS. And the question is, when do you remove the IJS? This is from Dr. Rodriguez Fontan. When do you remove the IJS? Do you wait 12 weeks? When is the ideal timing? We had Dr. Cassidy, I think, not remove an IJS because the patient didn't consent to it, which they're perfectly allowed to do. And so what are your thoughts on that?
I think the bottom line with the removal of the IJS is remove it when the patient has plateaued in rehabilitation, when he has reached maximal or close to maximal improvement. If we remove it earlier, the problem is not as much as recurrent instability. It seldom happens if you remove it after a month because the ligaments heal pretty quickly. But the problem is that they take a step back in rehabilitation. And I think it takes them longer to reach the final stage. But if you remove them when they have already plateaued in rehabilitation, they seem to have no problem getting back to the level they were just before you remove it.
Great. Anybody else want to comment on that? And maybe we can have the faculty turn on their cameras. So all the faculty, please turn on your cameras if you're able. If you're not, I totally get it. And maybe, yes, Dr. Cassidy?
Yeah, if the axis pin is in the perfect location and the elbow is stable, it won't ever be a problem unless it's prominent. So the connecting arm sometimes is prominent in really thin patients. So I don't really feel an urgency to do it. On the other hand, I have seen some patients who've had them applied where the axis was not in the right place and there's a lot of toggling, and that really worries me that maybe the elbow is not stable or there's a little bit of a cam effect that's occurred that may be contributing to the instability. So I think you really have to assess it critically, and if you're thinking about it, make sure the axis pin looks like it's in the right place, that there's not a lucency around it, and then there's no worries whatsoever to me. Either way, leaving it or taking it out.
And then a follow-up question to this, Dr. Neubauer asks about the IJS placement and the position of your lateral ulnar collateral ligament repair or reconstruction. And so how do you manage the IJS in the spot where the ligament should be?
Yeah, so I would use the same as I illustrated for the reconstruction. So it's important not to compromise the opening of the axis pin because we don't want to make that loose and have it start toggling. So I use Keith needles and drill them, one just distal to, aiming posteriorly, and one just proximal to, aiming posteriorly. And if you are doing a reconstruction, you can make a bone tunnel proximal to the access pin. That's, as long as it's a little bit away, it's not going to compromise the stability of the fixator.
Perfect. Thank you. Well, I think we're just a few minutes over, so I would first and foremost like to thank the faculty. These were fantastic talks. These are recorded, and so I am sure I missed some critical points here, and so I'll probably go back and review some of these talks for my future efforts in elbow treatment. I would also like to thank Skeletal Dynamics. They provided an educational grant so that we could have and host this webinar. It takes a lot of effort and finances to be able to do this. And so thank you to Skeletal Dynamics for sponsoring this webinar and allowing us to all gather together and educate each other on this very complicated topic. And on that note, I will turn it over to our fearless leader, Dr. Jane, who will close it out.
Yeah, no, thank you, Deana. Wonderful moderating to all of our fantastic speakers for a real comprehensive review of where we are in 2025 regarding elbow instability. And again, want to give a shout out to Skeletal Dynamics again for sponsoring this webinar. The Hand Association really appreciates your support for surgical education. I would also like to thank you, the audience, for sharing your evening with us, and invite you to join us for upcoming hand webinars. They can be located at the AAHS website at handsurgery.org. And otherwise, that's it. And have a good night.
Good night, everybody. Be well.